Friends, today our colposcopy सीखे program, that is the colposcopy training program, I'm going to show you certain colposcopic images of the invasive cancer. They are very pertinent questions asked by the gynecologists while getting the colposcopy training program, and I'm going to discuss with you each with the clarification. First of all, I would like to show you this retrospective study reported in 2015, which looked at the missed cases of CIN3 and cancer by cytology, HPV, and co-testing. So it is clearly visible that cytology misses 8.7% of the CIN3 cases and 12.2% cases of the cervical cancer, whereas HPV can miss CIN3 in 6% of the cases and cancer in 18.6%, while co-testing decreases that substantially in the terms that it can miss CIN2 in 1.2% cases, 1.2% cases, and cancer in 5.5% cases. So what basically people or the gynecologist ask me that why HPV misses the cancer, why it is so. The thing is, once the invasive cancer has established, the tumor is not dependent upon the viral infection. It goes on multiplication, the cells goes on multiplication, dividing, metastasizing, and invasion goes on. So, and it is not dependent upon the virus. That once the virus is not present, high risk HPV test will not detect the HPV at all. So now coming to the case. So now this is a case of abnormal bleeding where cytology report was HSIL, patient was HPV-16 positive, and I'm showing you the pathological report which said invasive cancer. So, and the gynecologist who had referred me, she wanted me to go for the colposcopy. So I'm going to show you the images in the next. So now here, if you see that there's a clear-cut picture of the cervical cancer. Here you can see that the cervix is eaten up like picture. And when we do the colposcopy under green filter, this crater is very, very clearly visualized. So they were asking why not to go for the colposcopy? Where is the newer scamocolumnar junction? Why acetic acid is not being, when we apply the acetic acid, why the acetowhite, dense acetowhite is not seen? Similarly, here again, I would like to show you the clear picture. Again, the after acetic application, you can see the crater is much more clear, and here whole of the columnar epithelialization or whole of the columnar epithelium is being replaced by the tumor. And when we apply the Lugol's iodine, rest of the cervix takes mahogany brown, but this takes like this. So why means not typical canary yellow? Why the CIN2 or the 3, this mosaic punctation, they require the intact architecture. That is that what you see, basically the punctation and mosaic pattern, they exist because the basement membrane is still intact. Once the basement membrane is broken, their hierarchy goes off. The basic mechanism of having fine or coarse punctation of the mosaic is that capillary loops, they are pushed up in a regular, orderly fashion into the papilla under a continuous epithelial sheet. Once stromal invasion occurs, the basement membranes is breached, epithelial architecture is destroyed. So the basic thing is that you have to understand that CIN2 or 3 criteria are designed for flat, intact intraepithelial diseases where the basement membrane is preserved. Once invasion occurs, the basement membrane is breached, the epithelial architecture collapses, and tumor neoangenesis replaces the orderly punctation or mosaic pattern with chaotic atypical vessels, while surface necrosis and ulceration replace clean acetowhite iodine demarcation. There will be absence of classic CIN signs in a grossly abnormal lesion because again, you have to understand that the basement membrane has been now breached completely. That is the criteria. And your IFCPC also says suspicious for invasion. It doesn't classify. In it, there's no word like clear-cut malignancy. So again, here in this picture, I would like to show you that the ulceration, there's a necrotic slough, there's a friable contact bleeding, there are atypical vessels, abrupt branching is seen here, and whole of the external os is distorted. As I was telling you that CIN2 3 colposcopic criteria versus signs of suspicious for invasion are different as compared to invasive cancer. So that is why the colposcopy is of no use when the invasive cancer is present. We need to take the biopsy because this patient was referred. I did the colposcopy to make them understand all these things. And that is why I'm showing you here. They were insisting for the doctor who had referred, she wanted to go for the ECC also, but there was no need actually. I did the ECC. That ECC also showed the invasive squamous cell carcinoma. Thank you.